Don't take it.
No, it needs, works
All
out.
right. Hello, everybody. Welcome again to our newest session over here. Today, we're going to talk about stuff that's really new and important. Our speakers are up to date 100% in, everybody knows about coronary artery disease and stents and all that kind of stuff. Nobody knows about the new stuff in arrhythmia. Nobody knows about the new stuff in valve replacement. It's all very, very new. It's something that you should all be aware of. You're also going to learn how to take your pulse, I hope, because half of you is going to get some kind of arrhythmia sometime. 10% of you will get atrial fibrillation. It's really important to know when these things happen before you get into trouble with them. Our first speaker, David Slotwiner, is an electrophysiologist. Anybody know what that means? Don't answer.
Electrocardiograms?
Electrophysiologist. Shocking. That means somebody who deals with the rhythms of the heart. He is the chief of cardiology at NYPQ now. He is terrific. I have used his services many times. He and his partner, Seth Goldbarg. They're terrific. And he's going to talk to you about arrhythmias. Please reserve your questions till both speakers are done. And I'll call upon you, raise your hands then, but please do not interrupt. Thank you.
Thank you, Mel, and thank you so much for the kind invitation. I was here, I think it was 3 years ago, and I had a great time, and a lot has changed since then, so I'm happy to be back. What I'll try to do today is explain a little bit about both normal and abnormal heart rhythms, and how we diagnose and how we treat them. And I'm going to spend the last part of the talk talking about the most common abnormal heart rhythm, which is atrial fibrillation, which I think probably many of you have heard, and as Mel said, about 10% of us will develop it. So whenever I meet a new patient or potential patient, I always like to start by first explaining what the normal heart rhythm is, because most people have never heard of, or don't really have a concept of what the heart rhythm is, and don't understand or don't know that the heart has a complete electrical system, which is what's shown. I think one of these is a pointer. Is one of these a pointer?
Yeah, the middle one.
The middle one. Oh yeah. So, which is what's shown here in yellow, sort of yellow. This is a picture of the heart as if it's sliced in half. These are the top chambers, which are called the atria, which are very small. They look bigger here than they actually are. The bottom chambers do 95+% of the pumping. But it's this electrical system, which is really nerves, which is what makes the muscle squeeze. So we're all born with a normal pacemaker at the top right chamber of our heart. And that's a specialized group of nerve cells that can actually create an electrical signal on a rhythm, usually about once every second. It, of course, speeds up when we're active and slows down when we're sleeping. But it creates that electrical signal, which first travels through the top chambers, causing them to squeeze and pump blood into the lower chambers. Then the electricity continues down these nerves, causing the bottom chambers to squeeze. And that's what we call the normal heart rhythm, and I suspect that's what all of our hearts are doing right now, hopefully. Now, I just put these two slides on here to explain that what we're not talking about are the coronary arteries, which feed the heart muscle with blood. These are the arteries that sit on the outside of the heart muscle and supply the heart muscle with its blood. Of course, if there's a blockage in one of those arteries, that's what we commonly call a heart attack. And if there are narrowings or blockages, we may recommend that somebody receive a stent or even have bypass surgery. But this system, which I colloquially refer to as the plumbing system, is really totally separate from the heart rhythm and the electrical system. Of course, one can affect the other, but they're completely separate. So a heart attack is not an abnormal heart rhythm. That would be a blockage in one of the arteries. Now, I also put this slide here. It doesn't show up all that well, but my colleague, Dr. Hussein, is going to talk more about this part of the heart, which are the valves of the heart. Now, many of you have probably heard of leaky valves or tight valves, and some of you may have either had a valve replaced or know somebody who's had a valve replaced. These valves are critically important and help ensure that the flow of blood continues in the right direction. Blood returns to the right atrium, right upper chamber, then goes to the right lower chamber and out to the lungs. Then it returns to the left upper chamber, down to the left lower chamber, and out the aorta. And those valves close after the blood flows through them so that when muscle squeezes, the blood doesn't go backwards. And those valves can become too tight or too leaky, and that's what you'll hear about next. But again, this is separate from what I'm going to be speaking about today, which is the electrical system, which again, we're seeing here. And this is just an animation to show the normal heart rhythm with our heartbeat starting with an electrical pulse from our normal pacemaker, traveling first through the upper chambers, then down through the lower chambers. And when we record an electrocardiogram, which is what you see here on the right, what we're doing is we're actually recording this electrical activity by placing stickers on the chest. Now, we place 10 stickers. The reason for that is so that we can see the direction of electricity from many different sides. But right here is a typical electrocardiogram, and you see that first little bump is the electricity passing through the top chambers. That very big spike is the electricity passing through the bottom chambers. And then that medium-sized bump is the muscle recovering. So we see here top, bottom, and recovery, which is the normal heart rhythm. Now, I've divided abnormal rhythms into two very broad categories, which is how we electrophysiologists tend to think of them. And the first category are abnormal slow heart rhythms. These are actually fairly straightforward. There are only a couple of types of slow heart rhythms. Basically, the two possible problems that can cause slow heart rhythms are either that our body's normal pacemaker may start to wear out as we get older, or the nerve that joins the electrical conduction system from the top to the bottom chambers may start to wear out. Both of these problems ultimately result in the bottom chambers beating too slowly, or sometimes even stopping completely. And so the symptoms that somebody might feel if they had one of these problems could be fatigue, may just not feel like you can do as much as you used to be able to do. It could be that you notice when you try to exert yourself, you get more short of breath, you get more winded, or it could be even fainting, which is, of course, a dangerous sign, and we always want to try to catch it before you get to that stage. But these are the two basic problems that can cause slow abnormal heart rhythms. Either our pacemaker failing, our body's normal pacemaker, or the nerve that conducts electricity from the top to the bottom. Now, the standard treatment is an implantable pacemaker once we've ruled out other causes. Of course, there are many medications that can slow our normal heart rhythm down, so we would want to try to avoid those medications. Sometimes those are medications we actually recommend after a heart attack, but they can cause the normal heart beat to go too slowly, so we wouldn't want to implant a pacemaker unless we had ruled that out. Also, Lyme's disease can cause heart block, which is what happens when this nerve stops conducting. So we would make sure you didn't have heart block from Lyme's disease, which we could treat with antibiotics. But usually it ends up that we need to recommend an implantable pacemaker, which is shown here. This is a pretty typical implantable pacemaker, which we place under the skin in the left upper chest. with two small wires that go down the vein into the heart. It's a very simple surgery, takes about an hour, and now with modern technology, you can live a completely normal life with a pacemaker, with no restrictions, no worries about microwave ovens, no worries about cell phones, and now even the newest pacemakers can go through an MRI scanner under certain conditions. So really, the technology has advanced tremendously. Now we're also implanting a new type of pacemaker where the entire pacemaker is actually placed in the heart by a catheter. So you don't even have this part here, and I think over the coming years we will see more of those types of pacemakers, and they'll probably replace many of these pacemakers that you're used to up in the left upper chest. Moving along, a more broad category of abnormal heart rhythms are fast abnormal heart rhythms. Now, to keep it fairly straightforward, I've broken these down into two very broad categories. Abnormal heart rhythms that are fast, that come from the top chambers of the heart, and abnormal fast rhythms that come from the bottom chambers of the heart. Focusing on the top chambers first, remember, because the top chambers are very small and they don't pump very much blood, it's not that critical that the top chambers beat. So if they beat too quickly, it's generally not life-threatening. Now, it could be because some people are born with an extra nerve that allows the electricity to get caught in a loop. Sometimes, this is where atrial fibrillation is, which we'll talk about later, which occurs generally as we get older, often with high blood pressure and other heart problems. And the symptoms that patients who have fast abnormal heart rhythms in the top chambers, the symptoms that they might experience vary tremendously. They vary from being completely disabled from shortness of breath and palpitations and chest pain to being completely unaware. And all of us who treat these patients will have stories of people who come in who go to their doctor for a routine evaluation and are found to have a heart rate of 170 beats a minute coming from the top chambers, and they'll have no idea whatsoever. And the opposite is true. Some people will have a heart rate of 120 beats a minute from an abnormal rhythm and be completely disabled. So the point I'm trying to make is that it's very hard to categorize these, and the symptoms can vary tremendously. And the same for the treatment. The abnormal heart rhythms that occur in younger patients are often related to abnormalities from birth, which can be treated with catheter procedures. As we get older, those abnormal rhythms tend to be related to other diseases like high blood pressure, diabetes, coronary artery disease, and there the treatment options are wider. Moving along to the bottom chambers of the heart. Now, the bottom chambers are absolutely critical to life, and so any abnormal heart rhythm that affects the bottom chambers of the heart can be life-threatening. And that's particularly true for any fast abnormal heart rhythm that comes from the bottom chambers of the heart. And can anybody tell me a common lay term for fast abnormal heart rhythms that come from the bottom of the heart that you have a device to treat right outside the door?
Defibrillator.
Defibrillator.
Exactly, yep. I'm very glad to see that there. So the most common abnormal heart rhythm that comes from the bottom chamber of the heart, rapid rhythm, is commonly known as a cardiac arrest. And that's when the electricity becomes completely disorganized in the bottom chambers and causes the muscle to beat so fast that it actually cannot pump. And the only way to save somebody's life is to give them a shock to reset that rhythm. But we only have 2 or 3 minutes at the most to do that, which is why it's so important to have defibrillators in public places as you do here, and even more so for people who we know are at high risk of having a cardiac arrest. We would recommend they receive an implantable cardioverter defibrillator, which can monitor their heart with every single beat and can give their heart a shock to save their life within seconds if they ever need it. Unfortunately, in the United States, about 350,000 people will die of a cardiac arrest each year. Most people fall into the category where we don't know that they're at risk, and so that's why learning CPR, knowing where the external defibrillators are, and knowing how to use them is so critically important. So I want to talk next about some of the common tools we use to diagnose abnormal heart rhythms, and I have a feeling many of you are familiar with these. The first one I mentioned briefly is the electrocardiogram. Here you see a typical setup. Here we usually use a total of 10 stickers, and again what we're doing is we're simply, through these stickers, we're simply recording that electrical activity from your heart. And that can tell us an enormous amount about the pattern of electricity and whether it's normal or abnormal. But often people will have very short episodes of abnormal heart rhythms. They might feel a palpitation that could last a second, a few seconds. It may occur just a few times a day or less. So in that case, we might recommend a monitor that they can walk around with for 24 hours, commonly known as a Holter monitor after the individual who invented it. And what that does is it doesn't record all 10 stickers, but it records usually 5 stickers, and it records the entire 24 hours, and that allows us to go back and look at that and see if any abnormal heart rhythms occurred during that period. And if they did, what we'll do is we'll try to see that pattern to understand, was it from the top chambers, was it from the bottom, or what was going on. But even 24 hours is not often enough. Sometimes patients will only feel something a few times a week or once a month. And so we have a new type of monitor. I actually brought an example, which I'll pass around, called a mobile cardiac telemetry monitor. And what it is, let me get it out of my pocket and start passing it around. This is an actual device, and I'll explain it as it goes around. It's basically a computer with a transmitter in it on a patch. And so what we do is we place it on above the heart here, and it records the electrical activity continuously, and it sends that information to a cell phone, which we give to the patient. And the cell phone transmits it back to the company, which then sends it to us. And if the patient feels anything, there's a little button on top which you can feel. You can press that. That marks the recording, and then on the phone they can tell us exactly what they felt. This list of possible symptoms, palpitations, fainting, chest pain, will all pop up. And so this records continuously for up to 30 days. And patients can shower with it, do all their normal activity. And that's very helpful for less frequent rhythms where we really need to be detectives. But even 30 days is often not enough. And so we now have this implantable heart monitor, which, as you can see, is absolutely tiny, which we literally inject under the skin in the left upper chest, just with some local anesthesia. And this has a battery that lasts, anybody want to guess how long that battery lasts?
A year.
10 years.
6 months.
10 years.
Between 3 and 4 years. So it's amazing. So this records, it doesn't record everything. It looks to see if something's abnormal, and then it will start recording. And then patients at their bedroom have this monitor which is placed at their bedside. And in the middle of the night while they're asleep, it wirelessly communicates with this device and sends the information back to us. So every morning we have 2 technicians who come in who monitor the thousands of patients we have to see if any abnormal rhythms have been reported. And if so, they'll send those tracings to us, and we'll call the patient and figure out exactly what it was. This type of monitor is particularly helpful for patients who come in to the hospital with a stroke, and we don't know why they've had a stroke, and we need to see if they might be having short episodes of an abnormal heart rhythm called atrial fibrillation, which I'll talk about more in a moment. Now the last type of monitors I want to talk about are a type that I think are particularly exciting, which I encourage each one of you to learn more about and consider acquiring. And these are devices which you can purchase yourself without a prescription, either over the internet or in stores, that allow you to record information about your heart rhythm, which you can then choose to share with your healthcare provider if you wish. And I've seen many people who have detected their own abnormal heart rhythms through this and come to me for treatment. The two options that I'm presenting here are the most commonly used one. One is called Cardia Mobile, and this works with any smartphone. And as you can see here, there's a little patch. You put 2 fingers on either side, and you're able to record a single lead ECG, just like we were recording here, and just like we were recording here. It allows you to record that, and then you can send it to us, either by email, or you can bring it to your appointment. But that can be a very powerful tool. It's not good, it's not that helpful if you just feel a palpitation for a moment and then it's gone. But if you feel something that lasts a few moments, long enough for you to be able to get that device out of your pocket and use it, it's perfect for that. We also use it for patients who we know have had abnormal heart rhythms who we're treating to help assess the effectiveness of the treatment. The slightly more expensive version is the new Apple Watch Series 4. Oop, can I just close that? Pop up like this one. Thanks. The Apple Series 4 watch, which can do exactly the same thing as the Cardia Mobile, but it does it right from your watch. The Apple Watch also will keep track of your heart speed from minute to minute, so that gives us an additional bit of information. We can see if the heart rate generally jumps up. And the other device that does that, thank you, is the Fitbit, one of the Fitbits. There are a lot of different Fitbits. Has everyone seen that wearable monitor?
No. Down there.
Oh, okay. Yep. You want to know how that monitor works? Sure. So that one is this one right here. So we place that, generally we place that in the office, and we would give you a cell phone that comes with it and several patches, and it records your heart rhythm continuously through little stickers on the back of the patch. And then there's the cell phone wirelessly sends that data to us. Let's see. So those are the consumer wearable devices, and I'm not covering blood pressure today, but that's another parameter which I encourage all of you to measure at home under the right circumstances, which I'm sure Dr. Mel has explained, because that data can also be very valuable to your healthcare providers to know what your blood pressure is doing at home over a longer period of time. So I'm going to close on atrial fibrillation. I don't want to take up too much time, but atrial fibrillation is by far the most common abnormal heart rhythm. It occurs as we get older. By age 70, close to 1 in 10 people will have it. Some people get it much younger than 70, others older. And the real fear with atrial fibrillation is that it can cause strokes. But let me first just explain exactly what it is. So here's our normal heart rhythm, as you recall, with each heartbeat starting from our normal pacemaker, then traveling through the top chambers down to the bottom. Remember the cardiac arrest rhythm that I explained, where the electricity becomes disorganized in the bottom chambers of the heart? Well, that's exactly what happens in atrial fibrillation, except it happens in the top chambers of the heart. Since the top chambers are not critical, it's mostly just a nuisance. And some people will feel atrial fibrillation terribly and be completely disabled. Other people will be completely unaware. But this is an animation to show the disorganized electrical activity of atrial fibrillation.
Scary.
Now, this is where the most dreaded complication from atrial fibrillation comes in. So this is a picture of a heart sliced in half. It's not that easy to see, but this is what the atria actually look like, the upper chambers, and this is what the lower chambers look like. And what many people don't know is that similar to the appendix in our intestines, the heart has what we call an appendage, which is a dead-end pouch that serves no function. And most of the time, like our appendix in our intestines, it doesn't cause problems, except when it does. And in atrial fibrillation, that's when it does. Because it's a dead-end pouch, blood flows very slowly there and can pool, and blood clots can form. And those blood clots in atrial fibrillation can be pushed out of the heart and go to the brain and causes stroke, which is why the most important thing we do for atrial fibrillation is try to mitigate or reduce any risk of stroke. And our therapies have evolved tremendously during the time of my practice. I'm starting to get old. For most of most of my career, we only had Coumadin or warfarin, which many of you probably are familiar with. It's a drug commonly known as rat poison, because it is the same thing as rat poison, which works indirectly to block a protein that we use to help form blood clots. But sometimes we don't need those blood clots to form, and so the drug makes it a little bit more difficult for blood clots to form. But have any of you taken Coumadin before? Okay, so you know, the problem with Coumadin is it takes about 3 days or more for a single dose to have an effect, and it's very difficult to predict what effect that dose will have for an individual. So it requires constant blood checks, and it's a very crude drug. If it was a new drug, the FDA would never approve it now. Fortunately, we have a whole new class of drugs, which I'm sure you've all heard of on television, thanks to the internet ads on television. And these are actually superb blood thinners. Pradaxo is the first one, followed by Xarelto, followed by Eliquis. And these work in a totally different mechanism. They have a much more predictable effect. They have a much lower risk of bleeding, and practically no side effects that anybody feels. So the vast majority of patients with atrial fibrillation we now treat with one of those drugs to reduce their risk of stroke. However, there are patients who cannot take blood thinners, usually because of a history of bleeding. And for those patients, we're fortunate to have an alternative now, a device that we're implanting called Watchman. Basically what it is it's a little umbrella-like device that we place right at the opening of that appendage to seal that closed. It's a very simple procedure, it takes about an hour, and that allows us to seal off the appendage and stop blood thinners after just a few weeks. So it's really a terrific therapy for patients who have had difficulty bleeding. You might ask, well, why don't we recommend that for everyone? And the reason is we have much more data on blood thinners, and there are other places that blood clots can form besides the appendage. So we're gathering more data on this device as we get experience with it. It's been approved and out for about 3 years, and it's doing very well. But at this point, you're definitely better off taking a blood thinner if you can. But if you can't, the Watchman is a superb option. And lastly, I'll just say, I didn't touch upon treatments for atrial fibrillation because that's a huge topic, probably worth a whole separate talk. But I just want to emphasize the symptoms from atrial fibrillation really differ tremendously from one person to another. If you have atrial fibrillation, you might talk to a friend who might have been recommended totally different treatment, and you might wonder who's right. And the honest truth is, it really depends on a lot of different factors. We look at what a patient is feeling. If somebody's not feeling atrial fibrillation, we might only recommend blood thinners. We look at their age to see what other comorbidities they have to determine what their risk of stroke is. And so it's really highly individual. But I certainly encourage you to read and talk to friends, but just know that that is why the treatments for two individual people with the same disease may be very, very different. So I'm going to pause here. I don't want to take up too much time. I'm going to turn this over to my colleague,